Let me tell you just a little bit about myself. I'm a humble country neurologist from Boulder, Colorado, who for 20 years ran a rehab center. I didn't do clinical neurology after the first 10 years of practice. I did rehabilitation medicine, and I ran brain injury programs, stroke programs, and chronic pain programs. And about 10 to 12 years ago, I had this, awakening on the road to Damascus or something like that, where I suddenly realized that trauma was the cause for all the distress in many of the patients that I saw who needed rehabilitation, especially chronic pain. And I discovered that many, if not most, of my chronic pain patients, in fact, had child abuse. And then I discovered that all of the 10,000 whiplash patients I'd seen had the trauma and the whiplash syndrome proportionate to their lifetime burden of trauma. That the whiplash syndrome was not a physical injury per se, it was an experience which changed the body. And the back pain, the neck pain, the dizziness, the visual problems, the emotional problems, all the things that happen with whiplash had a very logical basis in the memory for the events of that experience, which then were replicated in all the physical sensations of the injury. And that's what a lot of people were talking about up here. That's what Carol was talking about when she worked with chronic pain in the back and neck and these things. And that's why EFT works. I also realized that most of the chronic diseases to which we're subject also have their roots in the complicated way the brain processes traumatic experiences and the physiology of that process and how it affects the body. And so I wrote this book called The Body Bears the Burden, which now is obvious that it is the burden of trauma. And I mean the experience of trauma, not the physical changes of an injury per se. And I will explain in this talk why that happens, how the physiology operates, how it connects with the body and with the symptoms that one sees in chronic disease. And you'll come away with a new idea, I hope, which fits directly into how EFT works. And then I'll actually talk about what is the common ingredient in healing trauma and how does that relate to the various techniques that are out there, especially energy psychology. I take a different tack. I don't talk about energy per se, although the body is an energetic organ. There's a field that is perceptible, and some people can even see it. But the brain is what processes all of this. And the brain actually changes the body in ways that don't need to come from outside ideas about the way the body is constructed. So this is not an easy talk. It's complex. I will make it lay-friendly within the limits of what I can do. I will talk about some Latin terms like amygdala and hippocampus and things like that, just to have you understand and hear once how the brain processes it. And that also is necessary to explain how trauma works and how trauma healing works. So it will be challenging, but I will try to make it as clear as I can. And I will be signing books and answering questions for as long as people need after here. Well, I love the history of trauma because the history of trauma shows that back 150 years ago, brilliant physicians understood and knew and recognized what we now are beginning to recognize years later. And this begins back in the last part of the 19th century at the Salpêtrière, a hospital in Paris that housed criminals and what were called hysterics. And Jean-Marie Sarcot, who was a neurologist, studied hysteria with great interest because hysteria, or conversion reaction, is a neurological syndrome involving paralysis, seizures, loss of speech, collapse, fainting spells, numbness and tingling, and a host of neurological symptoms which were felt to be, at least at that time, malingering. They called it hysteria because 90% were women, and hysteria derives from the word hystera, which is the uterus. And people called it the wandering of the uterus in these women. Well, Breuer and his student Freud came to study at the Salpêtrière with Charcot, in the late 1880s. And they discovered that if you talk to these women, nobody had ever bothered to do that, they had what they called reminiscences. And the reminiscences often involved childhood events. And in fact, when they really got to the heart of matters with every one of these women, everyone was a victim of incest. They all were victims of childhood sexual abuse. Freud was entranced with this concept, wrote a brilliant article called The Etiology of Hysteria, and was criticized, marginalized, and almost cast out of many societies because the fathers of these women were often middle-class, prominent citizens of Paris and Vienna. And as a result, at the expense of his honesty and his integrity, he recanted and said that actually their hysteria derived from their incestuous lusts of their fathers, which was unacceptable, so they turned this into neurological symptoms which were disabling. They recanted, basically, he and Breuer. Pierre Genet was a psychologist at the time who also studied this. He understood hysteria. He described it in great detail, and his works today show that he understood things now that are just beginning to be re-examined and re-understood regarding the body and trauma. And he was, as a result, ostracized. Charcot presented these women at his Tuesday morning lectures. The audience was composed of psychologists, psychiatrists, and luminaries like great actresses and politicians and the like, who had come to see him demonstrate how he could trigger a hysterical attack in these women by touching a certain point on their body. It was always the same point for each woman. And there would be a point, it could be on the arm, it could be on the leg, most of it was in the lower part of the abdomen, big surprise there. And this triggered a hysterical attack, which often was a swoon in this case, or it could be a hemiplegia or a collapse and paralysis of the legs. So he demonstrated this in this sort of a circus at the time. Genet talked about fixed ideas, idea fixe, the spectrum of symptoms, which included body symptoms, somatic symptoms, emotional, perceptual symptoms where there was blindness or loss of speech, all triggered by a cue that related to the trauma. And the fact that these events occur with a specific cue is very important to the whole understanding of trauma and how it expresses itself in the body. They also had absent-mindedness. They were cognitively impaired. They had memory deficits and abulia, the inability to initiate action. In other words, they were often frozen in space, unable to move. And as I said, cues in the environment were noted to trigger this often. And sure enough, these are pictures from some of the Salpêtrière patients. All of them had neurological signs. This woman has what looks like is a hemiplegia, paralysis of the right side of her body. This woman looks like she is having a seizure, or actually this is the posture that the accident victim from an auto accident comes into where there's severe brain injury. It's called decerebrate rigidity. How did these women know that that's how the brain works? How did they know this? They didn't know this because hysteria is a physiological syndrome. We now know if you do energy scans of the brain that the parts of the body that are impaired, the representative area of the brain is also impaired, objectively, in this so-called psychological syndrome. So psychology, neurology, these are the same thing. The brain and the mind of the body are all a continuum. And one can have, in a psychological syndrome, evidence for physiological changes in the brain. Well, in World War I, which was a unique war because it was fought in trenches, the soldiers developed an unusual syndrome. Even as early as the Civil War, where there was a diagnosis called soldier's heart, soldiers were known to suffer from emotional distress in battle. In World War I, however, these soldiers were helpless much of the time. They were in the trenches, they were being bombarded, they had no way to protect themselves, and they developed what's dissociative symptoms. We talked about dissociation briefly, and they basically got stuck in postures and positions which reflected the last act of self-defense that they attempted before they became totally helpless. And these postures reflect the same type of thing that you see with the hysterical women. And then Sandor Ferenczi, who was a contemporary of Freud, described a tic. Everybody knows what a tic is. It's a habit spasm or a muscle movement that's repetitive and compulsive and seen in times of stress, as an overstrong memory fixation on the attitude of the body at the moment of trauma. It was a self-protective mechanism which stayed after the traumatic event. Why would it stay? Well, we're going to talk about that. Every time you see somebody with an eye twitch, a face twitch, a shoulder twitch, a clearing of their throat, a cough, that represents an old memory for a trauma that was never resolved. The roots of trauma require two elements: a threat to survival and helplessness. Trauma does not occur unless you're helpless. A threat to survival, of course, is relative. And Carol talked briefly about mini traumas. That's the topic of my second book, The Trauma Spectrum. Any negative life event that's severe enough to compromise your well-being, and therefore probably your survival, where you have no control, assumes the quality of trauma. Threat to survival and helplessness. And what that causes, of course, is what, can't remember your name, what you experienced, the freeze. Dissociation and the freeze are connected. The freeze response is the thing of most importance in the study of trauma. The freeze response is what the opossum does when he's run to the ground. He falls, he's immobile, he's feigning death. No, he's not. It's a physiological, unconscious, instinctual response. It's associated with flooding of the brain and body with endorphins, so you can't feel pain. It's associated with parasympathetic tone. The vagus nerve is the nerve that governs the operations of the viscera, the heart, lungs, and intestinal tract. And that organ, that neurological state is a high parasympathetic or vagal state, like when you're digesting food. But it's, as you'll see, a very profound state which can be life-threatening. If you've been running to escape, you've been in a sympathetic dominant fight-flight activity, high pulse rate, high heart rate, energy expenditure. If then you go into the freeze response, which is just the opposite, immobility, vagal, parasympathetic, you may for a while be in this wild state of hyper cycling between sympathetic and parasympathetic dominance. It's sort of the brake analogy phenomenon, the brake accelerator analogy. We mentioned endorphins. They're released in arousal. Endorphins are what allow you to escape if you're wounded. It's why soldiers don't feel pain for a while after the wound, how they can continue to battle even though they're wounded and then realize that they're mortally wounded. It mediates the freeze response as well. So during the freeze response, you're numb. And it's actually a state of analgesia and also, if you think of it that way, of mild pleasure because there's no sensation, thinking is dulled, and you're not in pain or terror anymore. Freud described hypnosis, which in some senses is related to the freeze response. He called it a paralysis produced by the influence of an omnipotent person on a defenseless, impotent subject. Influence and helplessness. Freeze, hypnosis. And Pavlov described it in his animals. When he was in the lab testing his animals, he'd bring them in, he'd pick them up at the legs, put them on the table, and they'd stay lying on their back with their legs in the air. Frozen, just like the soldiers, in the last posture before they froze. And actually, he was traumatizing his animals. And they were also in cages, which means they were not resilient. So the persistence of reflex motor postures is typical of this. And this has a lot of importance in the somatic syndromes that one sees after trauma. If an animal recovers and is not eaten or killed after they've frozen, they go through a very stereotyped response called the freeze discharge. And I'm going to show you the freeze discharge. Okay, what happens is that the polar bear, when he is anesthetized to be tagged, as he comes out of it, he's lying on his back, he begins to shake like he has a grand mal seizure. And if you look at it closely, what he's doing is he is running in place. He is replicating the last act of survival before he froze. He's discharging the freeze response by completing the act of escape. The polar bear has just been running from a predator. It finally found a predator in its life. And it's now getting sedated. Well, it's going to collapse because of the sedation, but it will also freeze because it's being traumatized. And as it comes out of it, it goes through what looks like a grand mal seizure. Now, if you watch the belly, at the end of the discharge, it completes the whole thing with deep inspiration, expiration. See the belly collapse? It's re-regulating its autonomic nervous system. Now, if you look at it slowly, it's running in place. It's replicating the act of escape. And it looks dramatic. It looks like a seizure. But it, in fact, is simply replicating what it needed to do to complete in procedural memory the events of that trauma, which therefore were extinguished, and it could go on with its life. That's all there is to it. Now, if you don't discharge the freeze response, it's very serious. It's not good for you. This is a little study done with baby chicks, and this investigator took these chicks and held them in his hand until they froze. They're naive. They will freeze if helpless and threatened. He then put them on the table and let them go and discharge the freeze response, which they did. Then he put them in a vat of water and tested how long they swam before they gave up and sank. It's a measure of resilience, very primitive test that Hans Selye did with his rats to study rat resilience. He then took a second group and didn't immobilize them, simply put them in the vat of water and measured their survival efforts through the time they swam. Then he took the third group of chicks, immobilized them, put them down, and then poked them with a pencil until they came out of it without discharging the freeze. And when they did, he put them in the vat, they sank to the bottom. In other words, having frozen, having discharged the freeze response provides resiliency to future trauma. And in fact, the chicks who had discharged the freeze response swam longer than the chicks who'd never frozen. So it has a purpose in survival and in resiliency. And some animals don't discharge the freeze response routinely. These are animals such as laboratory animals, domestic animals, zoo animals, human animals. And the common feature, of course, is they all live in cages. And we live in a cultural cage, which inhibits that instinctual response, which is why we are so easily traumatized. And it is a cultural phenomenon. Indigenous tribes routinely discharge the freeze, but acculturated urban human beings seldom do. Has a lot to say about the way we are and the diseases that we suffer from. Well, trauma is an aberration of memory. And to understand memory, you just need to know the basic categories of memory. You're using what's called conscious or declarative memory or explicit memory. It's memory where you learn facts and events, where you store information, you take a course, and you hope you remember everything that you've heard. Or you memorize long lists if you're a medical student, and you retain them long enough for the test, and then you forget them. Because declarative memory is very fragile, very subject to decay. I remember 20% what I learned in medical school. Very subject to decay. Trauma memory is held in non-declarative memory or implicit memory or procedural memory. These are the kinds of things we use to learn skills, how to learn a musical instrument, a sport. That's how we learn that, and they tend to be hardwired. When you learn to ski, you never quite forget all the nuances. You ride a bike, you can ride a bike the rest of your life once you've learned the skill. The important part of procedural memory from the standpoint of trauma is body memory related to conditioned sensory motor responses. Now, what's that? That's Pavlov's dog salivating at the bell when the bell has been paired with food. It always involves a survival skill. Procedural memory that's related to conditioned responses is a way we learn how to survive. We learn that spotted cats on the Kalahari Desert are to be avoided if we're a gazelle, and you got one trial to learn it. So they're very hardwired. Once you learn them, they're there. But sometimes procedural memory involves false cues and false information. And conditioning may occur when it's not appropriate. And the trouble with trauma is that there's a life threat while in a state of helplessness leading to the freeze. And if you discharge the freeze response, you complete the act of survival, and so that experience is not part of your conditioned memory as an ongoing present threat. And in trauma, if you don't discharge the freeze, you're conditioned to every nuance of that experience. Every nuance, every sensation, every thought, every image, every movement pattern that you did is stuck in your survival bank as a false memory, as if that threat is still imminent or dangerous. And as a result, if any cues from the environment, including your internal environment, arise, they throw you back into that experience. And you experience all of those things. Your neck gets stiff. Person who has just had a whiplash or an auto accident, their pain is gone. They get in the car, turn on the ignition, and their neck is in spasm. The cues have triggered part of that procedural memory, preparing them to defend themselves, even though the threat is no longer there. And so the threat, the body experience, the emotional state, the autonomic state, where the fight and flight, part of the autonomic arousal, all are stored in exact form in procedural memory in trauma victims, which causes a host of inexplicable symptoms, because as these states of trauma experiences develop and interweave with each other, all sorts of cues will produce all sorts of physical symptoms based on this procedural memory, which is false memory. And here's an example of a classic response. The baboon has assumed a defensive posture just before he's about to be throttled by the jaguar or the leopard. He's got his neck protected by opening his jaw and pulling his head forward and hiking his shoulders up. He's got his gut protected by folding up into a ball. This is a primitive posture of self-defense. And where do you see this posture? In old age? In chronic pain? In chronic illness? In depression? It is an instinctual activation of these muscles whose main purpose is self-protection and survival. And if you've had a lot of trauma, that's how you end up in old age. Not everybody acts. I'm really old. I stand up pretty straight. But that's because of all the trauma work I've done. How does this work in the brain? Okay, this is the hardest part of the talk. There are a couple names I want you to remember. One is the amygdala, right down there. The other is the orbitofrontal cortex, right up there, and the anterior cingulate gyrus. Because these systems have to be manipulated in order to heal trauma. One heals trauma by manipulating this circuitry, this trauma circuitry. What happens is we get most of our information from the head and neck. That's why we have a head and neck, is to access information. That's the main reason. Those warning signals are sent to different parts of the brain. There's a little area called the locus ceruleus, which is in the reptilian or brain stem, which sets off the whole system. It secretes a hormone called norepinephrine and kicks off the whole fight-flight response. The amygdala is a little almond-shaped lump in the survival brain, the limbic system, whose purpose is to evaluate the emotional content of a piece of information and then pass it around so that it gets operated on and the person or animal begins the whole process of self-defense. So the amygdala is the arousal system. Without the amygdala, you don't get aroused. One of the neurologists had a patient who had seizures. He did an MRI, both amygdala were calcified. So he decided, I'm going to test this person, see what they're like. And he found that that person was incapable of rage and incapable of fear. She wouldn't have survived on the desert, but she was very placid, and there's no way she would ever be traumatized. You need the amygdala to experience and suffer trauma. The hippocampus is the conscious memory center. It's the part that goes first in Alzheimer's disease. That has to do with declarative memory, facts and events. And that, when that is activated, the person begins to process the information of the threat. And the orbitofrontal cortex, which is on the right side, it's underneath the frontal lobe, right above the roof of the eye or the orbit. The orbitofrontal cortex organizes the response to threat. And if you're going to modulate a threat message as to its severity, you need a big orbitofrontal cortex. And as we'll see, the orbitofrontal cortex is dependent upon maternal-infant bonding for its development. And we'll talk about that. Without maternal-infant bonding, your orbitofrontal cortex is physically smaller and functionally less efficient. And you will be prone throughout the life to trauma and emotional distress. The anterior cingulate gyrus is important because it is one of the systems of the limbic system in this whole process that evaluates the severity and puts a damper on the amygdala. The damper on the amygdala if it's not that serious. So you need the cingulate to modulate the amygdala. Without it, the amygdala will go wild and every threat will be huge. And the cingulate gyrus has several important functions, the most important of which are social bonding, social interaction, and maternal-infant bonding. So enlisting bonding in the process of therapy, in other words, having a social connection, is probably the main ingredient in the efficacy of trauma therapy, because that inhibits the amygdala. And if you inhibit the amygdala, you can then extinguish a lot of these useless memories that float around in trauma. Okay, there's a lot more to say about that, but that's enough for now. The problem with trauma is that when these messages are stuck in procedural memory, they keep circulating, and they're self-perpetuating, and they actually make the process worse by themselves. And this is a process called neurosensitization or kindling, the development of self-perpetuating circuits, because trauma, once established, is self-perpetuating unless it's healed. And it will self-perpetuate both in the area of mental illness and emotional diseases, and the area of somatic illness and physical diseases. Now, resiliency versus vulnerability, I have implied already, is based on the absence of a lot of trauma in early childhood. Early childhood is when we develop our resiliency or we lose it, based on our early childhood experiences, some of which are by choice with maternal-infant bonding and a stable family and the like, some of which are not by choice with surgery, injuries, and other things that happen to kids that are very traumatic and can upset the apple cart almost as much as the bonding. So we need to understand how vulnerable or resilient a person is based on their childhood. That's where the bottom line is. That's the bottom line. Children are not resilient intrinsically. They're very vulnerable. And if a lot of trauma occurs as a child, you will be very susceptible to re-traumatization as an adult, even with what we might consider relatively minor traumatic events. And Alan Shore is a psychologist who has made a career out of this idea. He wrote Affect Regulation and the Origin of the Self. Nobody in this room has heard of that, I assume. Good for you. And has anybody? Did you read it? I've got a Purple Heart for you here. It's a really difficult book, but it's very important. He talks about the maternal-infant dyad, or two as one, the bonding effect of face-to-face attunement, and I mean face-to-face, eye-to-eye attunement between the mother in the infant at a distance of about 10 inches, which is the distance between the left breast and the right eye. That seems to be the optimal distance for that attunement to occur. And if it occurs, you can watch on MRIs the right frontal orbitofrontal cortex expand and grow, even overlapping the front of the left frontal cortex. And if it's absent, you won't see that happen. So this is how we gain resiliency. And that says a lot about other topics I talk about, including the American system of birthing, the hospital system of birthing, which impairs that. The legacy of impaired attachment and developmental trauma is a lifetime of autonomic and emotional dysregulation. Well, autonomic dysregulation, the autonomic nervous system controls the entire somatic sphere, and dysregulation of the autonomic nervous system will result in dysregulation of the endocrine system, the immune system, the entire disease-based function of the body. And this is what the autonomic nervous system looks like in trauma. It's a rocky road. In fact, if one looks at the dotted line as the smooth cycling of sympathetic and parasympathetic states, which we call homeostasis, the optimal static function of the body systems. By the way, vibration makes all sorts of sense because the entire universe operates on a sine wave, and so does vibration, and so does the autonomic nervous system, and the estrous cycle, and the cortisol cycle, and the moon, and the planets. They all operate on a vibrational frequency. And I think this is one reason why vibration is a valid way of looking at the healing process in trauma. In trauma, if you put an input in that's excessive, it results in gradual cycling of the autonomic nervous system to the extremes of its capacity. And that's this dysregulatory state that typifies trauma. And it typifies all the diseases of trauma, such as fibromyalgia, irritable bowel syndrome, esophageal reflux, interstitial cystitis, chronic fatigue syndrome, on and on and on, immune disease and the like. These are all autonomic systemic dysregulatory syndromes. And the problem with them is there's no endpoint. You take a test, depending on where the cycle is, the test will show one thing. You take it at another part of the cycle, it shows something else. So doctors don't believe these diseases exist. They think they're functional or psychosomatic because they can't find an endpoint to pin their picture on. They've got to have a picture and an endpoint. And it's not like just what's the blood sugar or what's your liver function test. It is a cycling syndrome where every part of that cycle has some pathological symptom associated with it.